Assalamu alaikum. Our lecture today will be about the proteinuria. Proteinuria is a common finding in clinical practice. Sometimes it may be due to an underlying serious disease, and sometimes it's just a transient finding. So, in this lecture, we will define the term proteinuria, the amount of the protein that appear in the urine to diagnose the patient as having proteinuria. Also, we will classify the proteinuria into many types, and then we will consider what are the investigational steps that must be done in case of proteinuria to reach to the correct diagnosis. And then we will take an example of a disease in which we will have proteinuria. This disease will be the nephrotic syndrome, and we will discuss the biochemical finding in this disease. The protein that appear in the urine, the majority arise from the blood through the glomerular filtrate. About 30 milligram per liter pass through the glomerular filtrate into the urinary tract, and this will be totally in the day will be about 5 gram per day. But all of these protein, or the majority, will be reabsorbed by the tubule, so that only 150 milligram per day of protein will appear. The source of this protein is the majority is from the blood through the glomerular filtrate. Also, some of the protein originate from the urinary tract and some from the vagina and prostate. The protein that appear in the urine, we have certain protein called Tam-Horsfall mucoprotein. It is secreted by the tubular cell, and it's a part of the cast. So we have daily less than 150 milligram per day of protein. This is the normal allowed quantity of protein that will appear in the urine, and usually it could be detected by special screening tests that depend on the reagent test strips. And this method for testing the protein in the urine using the reagent test strips depend on the indicator dye in the presence of the protein. Its color will change. Why a protein does not appear in large quantity in the urine, or why it doesn't pass through the glomeruli? Because the size of the pores in the basement membrane of the glomeruli is smaller than the size of the protein. Most of the protein are large molecular weight protein or molecule, so that they cannot pass through the size of the pores. The second thing that prevents the protein from passing through the glomerular membrane is that the basement membrane is negatively charged, and the protein are also negatively charged, so there be repulsion between the two that prevent the protein from passing into the through the glomerular membrane. If any disease, for example, there is immune complex disease and deposition of the immune complex in the glomerular membrane, change the size or change the charge of the basement membrane of the glomeruli, or if there is any distortion, any pathological process that alter these two factors, this will allow the protein to pass through the membrane, and it will cause proteinuria. We say that about 150 milligram per liter appear in the urine. What is the type of this protein? Usually it is of low molecular weight protein, can pass because their size is smaller than the size of the pores, so that they can pass. But once they pass through the glomerular membrane, they will be reabsorbed by the tubular cell, and catabolized and returned back to the circulation, while the high molecular weight protein cannot pass through the glomerular filter. As a part of routine testing and routine checkout, we will check the urine for the presence of a protein. We will use the reagent Dipstick, and it can detect the presence of a protein if it was more than 200 milligram per liter. We say that the daily allowance is less than 150 milligram per day. So if the quantity is more than 200 milligram per liter, then it can be detected using this reagent strips. One of the defaults of these is that they can check for the presence of albumin only, and they are less sensitive to the presence of other protein. So we can consider this test as a screening test. If it shows that the test was positive, in this case we must do confirmation by more sophisticated test. And in addition to the quantification, we also compare it to the creatinine ratio, albumin creatinine ratio, or we do a timed urine collection. For example, we collect the urine for 24 hours and measure the total amount of the protein that appear in the urine within these 24 hours, or could be a less period, for example, at 8 hours. So this is called timed urine collection. When we do a timed urine collection, for example, for 24 hours, we ask the patient to, for example, start at 8 a.m. in the morning. We ask the patient to make his urination, and we discard this sample and not include it in the collection. And then any urine sample after this sample will be collected in a container, and the collection will extend it to the 8 a.m. in the next day. At 8 a.m. in the next day, we ask the patient to urinate, and the urine sample will be added to the collection container, and we measure the protein that was discarded during these 24 hours, and then we can quantify it in a proper way. According to the defect, we can classify a protein into proteinuria into three types. We have the glomerular proteinuria and the tubular proteinuria and the overflow proteinuria. We will know how to differentiate between each of these type of proteinuria, what is the significance, and from the type of protein that appear in the urine, we can know the site of the injury. In case of glomerular proteinuria, from its name, it means that the defect in the glomerulus could be any pathology that lead to alteration in any, for example, in the pore size, in the charge, that allow the passage of the protein, and it's characterized by a passing of high molecular weight protein. Glomerular proteinuria can be differentiated from other type of proteinuria by the passage of the high molecular weight protein. Example is the albumin and the immunoglobulin, and there will be a stepwise increase in the size of a protein, starting from albumin and then to a larger and larger protein. For example, the IgG, which is a very large protein, will pass at a later stage. One of the markers of the severity of glomerular proteinuria is the selectivity of the protein that can pass. So it starts from lower molecular weight protein, then increase to a higher. If the patient pass very higher or very high large molecular weight protein, it means that the proteinuria is non-selective and has a bad prognosis. The patient with selective proteinuria, for example, just albumin, have a better prognosis than a patient who pass large molecular weight protein. We call it non-selective proteinuria. All type of protein can pass through his glomerulus. The other type of proteinuria is the tubular proteinuria, and this type, the damage from its name, it's in the tubule. The tubule normally reabsorb and catabolize the filtered protein. If there is any tubular damage for whatever the cause, then this will lead to decrease in the capacity to reabsorb the protein. This is characterized by normal glomerular permeability. And since the patient have normal glomerular permeability, it means that the high molecular weight protein cannot pass, just the low molecular weight protein can pass, but in this case, it cannot be reabsorbed. So there is no high molecular weight proteinuria, just low molecular weight proteinuria. For example, the retinol binding protein and the alpha-1 microglobulin. So to differentiate between the tubular proteinuria and glomerular is from the size of the protein. In the tubular, we have the low molecular weight protein. In the glomerular, we have high and low molecular weight protein will appear in the urine. The other type is the overflow proteinuria. In this condition, there will be the glomerulus is normal, the tubule is normal, but there is overproduction of certain type of protein beyond the capacity of the tubule to reabsorb it, so the excess will appear in the urine. So in the overflow proteinuria, we have first of all a normal glomerular function, normal tubular function, but there will be overproduction in certain type of protein. This overproduction is beyond the capacity of the tubule to reabsorb, so it will appear in the urine. For example, when there is damage to the muscle, and this is called rhabdomyolysis, there will be release of the protein that is found in the muscle, which is called myoglobin. It will be released in very large quantity, so the tubule cannot reabsorb all of the filtered myoglobin, and this will appear in the urine. In the case of multiple myeloma, we have a protein, Benzgen's protein, also produced in very large quantity, and the tubule cannot reabsorb it, so it will appear in the urine. And in case of leukemia, also we have a certain enzyme produced in very large quantity, is the lysozyme, and we will find a lysozyme proteinuria. So we have this in this type, in overflow. The production rate of certain protein will be high, normal tubule and glomerular function. The type of protein is usually low molecular weight protein, and there is no high molecular weight protein in this type because the glomerular is normal. We have a type of proteinuria called orthostatic proteinuria. This type of proteinuria usually occur after standing for a long period of time, and after standing we will find that the proteinuria will occur, and the certain age group are affected more than other by this type, usually the children and young adult, and it have a very good prognosis, and usually we can diagnose this type and differentiate it from other type because after sleep in the night, the orthostatic proteinuria will not occur, because one of the criteria to diagnose it is that the patient occur after standing up for a long period of time. So if we check an early morning sample, we will find that there is no proteinuria. We have a type called functional proteinuria or a transient, and may be associated with fever. So if the patient is febrile for a period of time, and we check by the reagent strip, we may found that this patient have a proteinuria. This is a benign, and it will disappear when the fever disappear. And also after heavy exercise or physical exertion, which is heavy physical exertion, or after severe trauma or in heart failure, all these may be associated with a transient functional proteinuria, and it is associated with the cause. When the cause will disappear, the proteinuria will disappear also. Sometimes the protein doesn't originate from the blood. It originates from the urinary tract itself. For example, if we have infection in the urinary tract or inflammation, then there will be excessive amount of protein from within the urinary tract, for example, from the sloughing or from the blood. This can be diagnosed by urine microscopy, where you can see the sign of inflammation or infection, and also we need to be the cells might be cultured, the urine sample must be cultured to find if there is any bacteria. This is the appearance of a patient with urine of a patient with proteinuria, and compared with normal urine. The normal urine usually is clear urine, while it will appear foamy in patient with proteinuria, foamy and turbid, cloudy appearance. All these we will describe the urine of patient with proteinuria. The next step. So if we found a patient on Dipstick, and we suspect that on Dipstick positive for proteinuria, is this enough to diagnose him by Dipstick testing once? The answer is no. It is not enough if a patient shows a positive reaction on Dipstick for protein. It must be confirmed by more sophisticated quantitative laboratory test, and more than one time, because it mainly may be due to, for example, fever or exercise. So we must confirm it at least for twice, and in the lab, not only in the Dipstick testing, not enough. And we prefer the early morning sample. We ask in the history, we exclude other causes, for example, the fever. We ask him if he have fever in the previous few days, if he have exertion or exercise, heavy exercise or physical exertion, or burn, also must be excluded before we decide that this is a serious proteinuria. Also, we exclude the orthostatic proteinuria by taking a morning sample. The orthostatic proteinuria is the proteinuria that occur after standing for a long time, mainly in the in the children and young adults, and can be diagnosed by taking an early morning sample. We can find that after sleeping for overnight, we will find that the urine became free of protein, or at least the amount of protein decreased. Also, we can exclude the urinary tract infection by taking we ask the patient to collect the midstream urine by discarding the first part of the urine, and then we collect the midstream and we check it for the presence of the pus cell, the bacteria, and we culture it for the presence of the bacteria. So all these causes must be excluded before we think that we have serious glomerular or tubular proteinuria. So first of all, we must check it twice, and we must ask in the history about any cause of transient proteinuria, for example, fever or exercise or exertion. Also, we exclude the orthostatic proteinuria by taking a morning sample, and we exclude the urinary tract infection by taking midstream urine and send it for cytology and culture. And also, we must be sure that it is not a transient proteinuria by checking 2 or 3 occasions and in a sophisticated quantitative method in the lab and not depending only on the dipstick testing. Then we will, if it is confirmed by doing it twice and we exclude all the previous causes, we will do the test for the renal function. For example, for the glomerular function, we can measure the plasma creatinine or the creatinine clearance, for example. And if plasma creatinine is high, it means that this waste product is retained by a defect in the glomeruli. Plasma creatinine is a test of glomerular function. So if it is elevated, it means that it is retained and cannot be excreted properly in the urine. So we will also check the albumin for the hypoalbuminemia and hypoproteinemia. This is a consequence of proteinuria. We will check if there is hypoproteinemia and hypoalbuminemia due to excessive renal excretion of these protein. Taking drug history, for example, certain medication may cause renal damage and it may be the cause of this proteinuria. The famous drugs that cause damage to the kidney are the gold and the penicillamine, and sometimes the proteinuria or the damage to the kidney, the nephropathy, is part of a systemic illness. For example, diabetes mellitus cause diabetic nephropathy. So in this condition, we must ask for the history of diabetes, and we check for the presence of for the blood glucose level, the hemoglobin A1C, for the presence of glucose in the urine, and also other disease may cause many systemic disease, rheumatological disease also may lead to nephropathy. So all this must be checked. Then after that, we will do electrophoresis to see the pattern of the proteinuria, whether it is glomerular, which is characterized by high molecular weight protein, mainly in addition to the low molecular weight protein, or tubular proteinuria, which is characterized by low molecular weight protein in the urine. This can be done by electrophoresis, in which the protein can be separated using special gel. Also, we check for certain protein. For example, when we see that the total protein urea is high, the quantity is more than 200, then we will check for the not only albumin, and we will check for special test for myoglobinuria, for hemoglobinuria, for Bence-Jones proteinuria in multiple myeloma, and each of these protein have a specific test that can be used to detect them. And in addition, we want to know the degree of proteinuria. It is not enough only for knowing that the patient have proteinuria. We want to quantify the amount of proteinuria. This can be either by collecting it over a timed period, for example, within 24 or 8, or compare it with the creatinine test. And also we can, for the cause of proteinuria, we can perform the autoantibody, for example, the streptococcal antibody, the antiglomerular membrane antibody, the complement C3C4 for the cause of, for example, glomerular nephritis. And later on, we can do the renal imaging, for example, ultrasound, CT scan, MRI, and renal biopsy may be indicated in certain conditions to diagnose the type of, for example, glomerular nephritis. Nephrotic syndrome is an example of a disease with proteinuria, and the defect mainly is in the glomeruli. So the type of proteinuria in the nephrotic syndrome is glomerular proteinuria. The defect usually is characterized by heavy proteinuria, at least 3 grams per day, and or we can measure it in another way by the ratio of protein to creatinine, which is more than 300 milligram per millimole. As a result of the proteinuria, the heavy proteinuria, the protein in the blood will decrease, and there will be hypoproteinemia and hypoalbuminemia. And as a result of this hypoalbuminemia, the oncotic pressure will decrease in the circulation, and this will lead to edema. So one of the characteristic feature of this syndrome is the peripheral edema secondary to hypoalbuminemia and decrease in the oncotic pressure and escape of the fluid from the circulation. Usually other biochemical finding is the hyperlipidemia and the hyperfibrinogenemia, the increase in the level of the fibrinogen, and there will be dyslipidemia with it. The abnormality in the protein, first of all, started as selective with appearance of only smaller molecular weight protein. Later on, for example, the albumin molecular weight matter is 65, and then later on there will be transferrin, which is a bit larger, 80 kDa, kilodalton. Later on, with advanced disease, there will be increase even the immunoglobulin, which are very large protein. For example, the IgG. The molecular weight is twice that of the transferrin and more than twice the level, the weight of the albumin. So the degree, the selectivity of the protein that appear in the urine can give an idea about the severity of the damage. If we do electrophoresis to these patients in the serum and in the urine, we can see the pattern of the a change that occur in this disease. What is the electrophoresis? I will remind you about it. It is an easy, inexpensive method of separating protein. This separation depends on the charge of the protein, on the size of the protein, and on the shape. As we know, we have two major type of protein in the blood. We have the albumin in the serum. We have the albumin and the globulin. The albumin is the major protein and represent the largest peak. This is the albumin. The black is the normal, and the pink is the example in nephrotic syndrome. First of all, we will explain we will remind you of the normal. This is the peak of albumin, is the largest peak, and it is like close to the positive electrode, while the globulin, they are the smaller fraction. We will look at the black line. These are the globulin. We have the alpha 1, alpha 2, beta, or sometimes the beta is divided to beta 1, beta 2, and we have the gamma globulin, and the gamma fraction is close to the negative electrode. This is the normal. In case of nephrotic syndrome, what will happen? Since there will be hypoalbuminemia, we will see that the level of albumin, this is the protein, serum protein electrophoresis, not the urine. We will find that the peak of albumin decrease, so the quantity of albumin is low, and also we have the alpha 1 also decreased, alpha 2 increase because it is a high molecular weight protein, so it will not appear early in the urine, and there will be a compensatory increase in the synthesis of the alpha 2 macroglobulin, and the gamma globulin, either it is according to the stage of the disease, either it is normal or it is decreased. This is the protein electrophoresis in pink or in the red. This is the protein electrophoresis in the serum. So we have decrease in the albumin, decrease in the alpha 1, and the gamma alpha 2 increased because it is large size. So in the beginning, it will not appear through the glomerular membrane, and it will increase in the circulation because of its large molecular weight. Later on, with advanced disease, it will decrease, And if we do urine electrophoresis, we can see also the pattern of the protein that appear in the urine. One of the findings is that because there is decrease or there is increase in the excretion of the protein in the urine. Some of these protein are bound to binding protein are bound to important analyte in the body. For example, we have the thyroxine binding globulin attached to thyroid. Thyroxine carry thyroxine. We have the cortisol binding globulin carry the cortisol. We have iron attached to the transferrin, and also we have the ferritin. We have the calcium attached to albumin. So when we measure these analytes, we may see that the level of these analytes are low. In fact, they are not low, but because the binding protein is decreased, because it appears in the urine, as a result, the concentration of this analyte in the circulation appear low. So we must put in mind that this decrease is not real. It is secondary to decrease in the level of the binding protein because these binding protein appear in the urine. Also, we have dyslipidemia in nephrotic syndrome in the form of increase in the LDL, and in a later stage of the disease, we have increase in the level of the VLDL. The glomerular function in the beginning, the urea and creatinine are normal. Later on, the patient may enter into the renal failure and their level start to increase. In summary, proteinuria either is glomerular or tubular or maybe overload proteinuria. The investigation that must be done in a stepwise manner. It means that first we must confirm that the patient have proteinuria by repeated test 2 or 3 times, and then in a sophisticated, not depending only on the dipstick reagent test. And after that, we exclude the orthostatic proteinuria. We exclude the proteinuria that occur secondary to fever or exercising, and also we exclude the proteinuria that arise secondary to, for example, infection in the urinary tract. And later on, we start more investigation to differentiate whether it is tubular or glomerular proteinuria. The other disease in this lecture was the nephrotic syndrome. It is a glomerular proteinuria disease, and it is associated with peripheral edema and hypoalbuminemia secondary to loss of albumin in the urine, and hypoproteinemia also secondary to the increased or excessive loss of the protein in the urine, in addition to the dyslipidemia. Thank you.